In this video, we will explore causes of refractory chronic cough, RCC, and latest thinking on treatment strategies to address clinical challenges of this common and hard-to-treat condition. One key challenge of treatment is preserving the normal cough reflex, a vital protective mechanism, while treating the pathological cough reflex associated with RCC. Let's look at how cough is initiated. Cough-evoking triggers reach the lining of the larynx, bronchus, and trachea. In the epithelial layer of these airways lie irritant neuroreceptors, which become stimulated by contact with cold air, capsaicin, or acids. This initiates the normal irritant route of cough generation, a vital protective reflex, protecting against aspiration from above and below. The signals are transmitted via vagal afferent sensory nerves through the jugular and nodose ganglia to the cough center in the brainstem. Its stimulation induces the cough reflex, which is transmitted via motor efferent nerves to cause contraction of the larynx, diaphragm, and intercostal muscles. Stimulation of the cough center also sends signals to the higher brain, which regulates urge to cough and the process of coughing. Cortical influences modulate the reflex, and central mechanisms for RCC have also been postulated. Simultaneously, normal cortical descending inhibitory influences are diminished. The normal irritant cough pathway described is a vital protective reflex and contrasts with a pathological cough pathway in patients with RCC. This pathological cough pathway involves sensory neuroreceptors, including P2X2 and P2X3, being stimulated by ATP originating in damaged epithelial and immune cells of the lung. The pathological cough signal, once initiated in this way, is transmitted to the cough center and higher brain as before. This pathological pathway may also contribute to cough hypersensitivity, an overlapping condition of which RCC is the subset of refractory patients who do not respond to treatment of treatable traits, for example, asthma. Potential therapeutic strategies for RCC include agents which act on the central or peripheral receptors. The most well-known drugs for cough treatment act centrally on neuroreceptors in the cough center. Opiates are agonists of mu-opioid receptors. Dextromethorphan is an NMDA antagonist. They mimic the central inhibitory pathways already described and suppress both normal irritant and pathological cough. Diphenylhydramine and other first-generation antihistamines are H1 antagonists, which may also work in the cough center. One of the most promising new strategies for pharmacological treatment of RCC involves P2X3 receptors, mainly located peripherally and found in the epithelial lining of the upper airways in afferent sensory nerve endings. They are involved in peripheral cough signal input and transmission to the CNS. They are ligand-gated cation channels, whose ligand is ATP, which is released in response to damaged epithelium and inflammation in the airways. In non-clinical experiments, P2X3 receptor antagonists inhibited action potential to an ATP analog and cough response. Experimental P2X3 antagonists have shown promising clinical efficacy in patients with RCC. P2X3 receptors may play a pivotal role in transmitting the pathological cough reflex, but not the irritant reflex. This has been suggested because capsaicin and citric acid-induced cough is not suppressed in patients by P2X3 antagonism. P2X3 receptor antagonists therefore have the potential to effectively treat RCC whilst leaving intact the vital irritant cough reflex.